Hello and welcome to the webinar, Rural Health Centers, Wyoming's Story. My name is Melissa Da Silva and I will be acting as moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. Thank you again for joining this webinar on Rural Health Centers, Wyoming's Story. And I now turn the mic over to one of our two presenters today, Mr. Pat Monahan. Pat?
Thank you, Melissa. I appreciate the audience being out here, and we're looking forward to sharing some information with you about Wyoming and our perspective here, which may be a little different than other communities represented on the phone and, of course, across the country. So here's a list of information we're going to talk about today. We've got a poll coming up on our first couple of slides, and we're going to have Melissa give us some direction on what to do there. We're going to cover what's going on here in Wyoming currently, what we're going to do in the future, and we're going to highlight one community, which is Rock Springs, Wyoming. We're going to talk about just kind of a wrap-up of where we're at and where we want to take things here in the future. So for introductions, my name's Pat Monahan. I'm the director of the Primary Care Association here in Wyoming. I've been with the organization for 5 years. At one point in time, I was an Air Force medical administrator, which is what brought me to Wyoming because I'm originally from Syracuse, New York. So I've got, and I lived there almost 30 years, so I've got a different perspective. Although I never worked in healthcare in a metropolitan area, I do know the difference between urban and rural areas, and I do think I bring a little different perspective, not only here to Wyoming, but also to be able to share our story, both with folks here in the audience today and anybody who'll be listening to this recording in the future. And I'd like to take a minute to let my co-presenter, Ms. Tina Linkenauger, who's the CEO of the Community Health Center in Rock Springs, Wyoming, to do an introduction for herself. Thank you, Tina.
Thanks, Pat. My name is Tina Linkenauger, and I am the CEO of the Sweetwater County Community Health Center, which is located in the southwest corner of Wyoming. This has been a career change for me. I had originally been in healthcare and most recently have been a real estate broker for the past 15 years. But I think that my heart has always been in healthcare, and that's what I wanted to go back to. I saw a need for a health center, and we have been working on that for about 3.5 to 4 years. So this is something that has not sprung up overnight and has been kind of a long process. I have attended a number of NAC meetings during this journey to get to the health center, and currently are working with both USDA and HRSA, so I'm very familiar with both of those federal programs. And I am a proud member of our Wyoming PCA. So I thank you for your time this afternoon, and we hope that we can share some of our Wyoming stories with you. And here's Pat.
Thanks, Tina. We have an interesting partnership, and maybe unique and maybe one that other folks can model with the National Healthcare for the Homeless Council. About 6 or 8 months ago, I got some emails from Melissa and some other folks at the National Council that just had offered up an opportunity to do some presentations here in Wyoming in communities that had healthcare for the homeless clinics and also possibly communities that did not. So we went back and forth via email and some phone dialogue for a couple of weeks, and then we settled on Jackson, Wyoming. So the National Council and the Primary Care Association co-facilitated a presentation up in Jackson, Wyoming. The TV show Modern Family with Ed O'Neill and a couple other folks has filmed their opening segment for this year's season up in Jackson. It's a very, very beautiful place. It's on the fringe of 2 national parks, Teton National Park and also, of course, Yellowstone National Park, but it is a very expensive place to live. It's a place that has a lot of folks that have in terms of economic, social, cultural resources, and a lot of folks that are without. So the council did a fantastic job ahead of time of doing some community outreach. They reached out to the hospital, local public health nursing, folks that were provided to them, both social services and healthcare, pulled the community and then pulled together our office and the community members for a presentation about 4 weeks ago. And it was the first time that the National Council had gone out and done some work in a community that did not yet have a clinic. But I think it was a great exercise for everybody to go through, because we realized that, yes, there's millionaires that live in that community, but there's also folks that make $6, $8, $10, $12 an hour, but they have to pay an inflated price for gas, for food, for housing, all those things. So I think it's a great partnership that we're going to build on for a long time to come, and it's actually what brought us here together today on this combined presentation. And I'd like to thank the Council immensely for this opportunity and for their work here in Wyoming and the work to move forward with us. And thank you again to the Council. So this is our poll here, and you can see the questions in front of you. I'm going to turn the microphone back over to Melissa to run us through the poll question. Thank you, Melissa. Turning the microphone back to you.
Thank you, participants. It looks like we have a couple of urban sites and a couple of no affiliation sites. It's 50-50 split between urban and no affiliation. Thank you, participants. I turn the mic over to Pat.
Thank you, Melissa. And the reason for putting that question in is so that we can know actually who we're talking to. So as I stated earlier, I spent a large part of my life living in an area of the country. I wouldn't say it was an enormous urban area, but I am aware of urban issues. And now for the last 12 years, I've lived both in South Dakota while I was in the Air Force and then here in Wyoming. So I've got a good experience in terms of rural America, and it's important we know who we're talking to out there so we can talk about some of our challenges. Here in Wyoming, as in every other state, we've got a number of components that make up our safety net. So we've got rural health clinics, we have free clinics, and of course our community health centers. I've had conversations with some of the rural health clinics here in our state about, and as it says on the slide, whether or not they want to convert from a for-profit entity to a nonprofit model. And some of the challenges with our partners that are rural health clinics is they come back to me and said, Pat, we like what we're doing here. How does it work if we're a community health center? So then when we bring in the concept of having a community board and the fact that our health clinics are working with the hospitals and maybe long-term care facilities and some of the other entities in their community to receive revenues, and that if they went to a community health center, they'd have to have full-blown disclosure of financials, some of the staffing models, and we're talking about tiny communities of just a few thousand people. In most cases, I've heard from the rural health clinics, thanks but no thanks. We get higher reimbursement as it is. We don't get as good of a reimbursement as we would get with a health center, but we're comfortable with where we're at. The free clinics have presented us lots of opportunities from a different standpoint. A lot of them are coming to me and saying, how can we exist? For everybody in the audience that's aware of a free clinic, I'm going to make sure that everybody kind of understands how we do it here. What we have with our free clinics, they're of course governed by a board, also a nonprofit. Most of them get funding maybe from the hospital, local providers, just local benefactors in the community. In some cases, we have United Way programs, but again, we're a fairly rural state, and you'll see what that in the slides coming up. Most of them just come to me and say, hey, Pat, I've got a small pocket of money here, and I've only got about 2 more years of operating money. What's the difference between a free clinic and a community health center, and how can we make that work in here in our state? Presently, we have two free clinics that we've made attempts to work with but have just said thanks but no thanks. And we've got 2 free clinics that are really strongly considering making this move for the community health center. And as you know, just from my brief explanation of what a free clinic is, they, meaning a free clinic, have most of the mechanisms in place to make that move. Here in Wyoming, we have 2 community health centers providing services in 4 locations, and what we have that's really working quite well is our primary community health center here in our state that serves about 15 to 20,000 people, is working with the smaller health centers, including Tina's, and we'll talk about this in a minute, to offer some management agreements. So what does that look like? It's not a satellite mechanism that a lot of us are aware of. What it really is more than anything else is offering support for IT, finance, risk management, any of those kind of things. but it's a great opportunity and an example of collaboration, because a newer health center such as Tina's doesn't need to go out and acquire that knowledge right off the bat. They can actually leverage that resource from an existing health center. So that's something we have here in Wyoming that may or may not exist in other states. I'm sure it does. But the fact that our knowledge base is deep in this organization is really helpful throughout our state. The last item on this slide is our legislature. Our legislature is very, very open, very understanding, and very hopeful that we as a state can end up with more health centers here through whatever the funding looks like through 2014, 2015. We have an excellent advocacy director here for our program. Our state legislature has provided one cycle of funding. It's $1 million. Some of the states represented, that might not be a lot of money. For our state, it's a fantastic pot of money. And the purpose of that money was for expansion of existing clinics or new clinics such as Tina's through both capital and or facility construction projects and purchase of equipment. But our legislature had come to us and said, we hear a lot about health centers. What can we do to help you? We put a proposal in front of them. They support it, and again, it resulted in some legislation for us. We're pretty excited about that. This is a map here of our state, and I don't expect you to read all the little counties. You can tell we've got 23 counties here in the state. And what I'm going to do, it would be nice if we could overlay these two maps, this one and the one following us. But this is a huge challenge for our state. We just hosted a meeting yesterday here to do some education on the ACA, and the governor's office came out, and the information that this woman used yesterday was 80% of everybody that lives in Wyoming seeks health care outside of Wyoming. And again, this may be unique across the country, it may not be. A little hard to see from the slide, but we have 6 different states that border us. Starting at the top, Montana, South Dakota, Nebraska, Colorado, Utah, and Idaho. Each and every one of those states has a larger metropolitan area where people go to not only for their health care, but while they're out and about, they do their shopping and a lot of their cultural and other type things. So we have some challenges in terms of retaining people here in our state. On this population map, and we're trying to model this map in terms of community health centers that exist and ones that we plan in the future. And we had a great opportunity within the last month to host our project officers, and we took them all over the state. My office is located in the southeast corner of the state, so it's your lower right-hand corner, and the clinic that Tina represents, you can see it's got some of the larger dots there. The clinic area that Tina represents is 3/4 of the way over to the left. And again, you can see there's a lot of driving distances between these two communities, but when you get to those communities, people live and work there. Our other health centers are located in Casper, which is it's the central part of this map here, over towards the right, and then again to Riverton, which is over also to the right, and this is about the middle of the map. So Jackson Hole is located over on the left-hand side, and kind of on where the two big grouping of dots are. And then on the northern tier, we have nothing. So to the middle of the map, where the red line is, that's Interstate 25. That's where Sheridan is at. And Sheridan is very interested in a community health center. And then moving back over to our left is where we have Cody Powell. Both of those communities are free clinics that are contemplating that conversion. So you can see here in our state, we've got large distances to drive. When you do drive there and you come through these little towns, people do live and work there. It's very hard for us to put that in a narrative for somebody that does not live or work in an urban area for them to understand, especially when we've got some reviewers that may not understand some of our dynamics. There are communities that we have been into where there's a lot of folks that are elderly and homebound. And they've told myself and the other folks that work for the Primary Care Association, we're just not leaving here. So how can we work to be able to get a program in some of these rural communities? The one thing that's really kind of worked against us is the current designation process, and that's on our challenges slide, so I'll leave that for then. But just some seed to plant prior to getting to that point. If you look at how the designations are built, if we've got a community with 2,500 people and one provider, we're determined to be, again, according to the current standards, adequately staffed. That does not allow for vacations, providers that have families, any of those kind of things, family emergencies that come up. So we do have a little different and a unique perspective than maybe other parts of the country. This is a picture of the Sweetwater County Community Health Center, which is in Rock Springs. So this part of the presentation I'm going to turn over to Tina. And I want to say thank you and looking forward to filling in some of the gaps when we're all done. Thank you, Tina.
Thanks, Pat. I appreciate this opportunity to talk about Wyoming. I see that based on our poll that most of our participants are from urban areas, so this might be a little bit enlightening for you to see what kind of things we experience here in rural America. This is a picture of our health center, also with a little spotlight from the National Association of Community Health Centers. So if you get a chance to take a look at it, we're pretty proud of our location. I wanted to talk a little bit about why we decided that we needed a community health center in Sweetwater County. Sweetwater County is a large area that encompasses a huge area mass and has about 43,000 people that make up Sweetwater County. In that community, we have 7 tiny towns. A tiny town is designated as an area that has 200 or less in population. Those are spread out among our whole community, and then we have 2 larger urban area, or we call them urban areas. They're not urban at all by United States standards, but we have 2 larger towns, which is Rock Springs and Green River, that are about 12 miles apart. In our county, we are experiencing a significant lack of providers, both medical and dental providers. That has caused a lot of challenges to our community. One of those being that a lot of the providers are unable to see Medicare or Medicaid patients. In fact, recently we had spoken with our Department of Family Services, and less than 5% of our Medicaid recipients have an established provider either for medical or dental services. In the case of our Medicaid recipients, most of those patients are not being seen unless it is on an emergent basis. So obviously, as you can tell, that creates a lot of problems for our healthcare system. We also just simply do not have enough providers to see all of the patients that we have, regardless of their ability to pay, regardless of their insurance source. For us, we are approximately 150 miles from Salt Lake City, Utah. So what that means is that the majority of our patient flow goes out of our state. This causes a lot of economic issues for us, as well as provider issues. Sometimes those patients are not able to travel the distances that we need to get to another provider. We also have very little specialty care in Sweetwater County. Everybody that we do have primarily is a family practice physician or a pediatrician. Therefore, any of our specialty services have to be sought outside of our community. Follow-up is a problem. And quite honestly, just because of our location and the inclement weather that we have, travel is an issue. In our particular area, we do not have anything other than our hospital that provides after-hours care. So if a patient or a child is sick in the evening or on the weekend, there is nowhere for them to go. There are no choices available. We also do have a community nursing program. Our community nursing program does an awful lot for our community. They do provide a lot of testing services. They provide STD testing, they provide flu testing, but they don't provide any treatment. So if you are tested positive, there is nowhere for you to go to receive care. This is obviously a problem. You know, we have a disconnect there, and we're trying hard to remedy that situation. We also have another issue that our medical or dental providers in Sweetwater County have chosen not to see any pregnant women for any illness during her pregnancy. So if a woman gets pregnant, has the flu, there's nobody to treat her. This is obviously another issue that we see as being a barrier to care for a lot of our patients. We have no providers that are willing to see patients on an income-based fee schedule. So if you perhaps don't qualify for Medicaid services, you don't make enough that you can pay full price for services, there are no options available for you in our area. And we have so few providers, and our providers in our area are doing everything that they can to see all of the patients that they can, but we're just not able to meet that need. So unfortunately, our providers are seeing patients that are in need of emergent care rather than being able to provide preventative services for those patients and seeing them before their diseases turn into a worst case scenario. We would like to see that we can provide more preventative care, more education, perhaps spend a little bit more time with patients, but when our providers are overwhelmed with the number of people that they do need to see, unfortunately, this is one of the areas where things fall through the cracks. And most importantly, I think that the reason that we have been working towards a community health center is because we saw that there was a need, and we saw that there were a number of barriers to care for our citizens in our area, and we wanted to take action. We didn't want to wring our hands and say, oh, we have a problem and we don't know what we're going to do. We decided that we needed to open up a community health center. And this has been a long road, but we still think it's the right thing to do. Sweetwater County Community Health Center's current status is that we have recently applied for a lookalike status for a community health center. We did apply for 330 funding in December of 2010, and we were very confident that we would be one of the areas that were selected for funding. However, unfortunately, with the budget cuts and the way things went, we were not successful. So we found out about approximately a month ago that we did not receive our lookalike, or our FQHC status. And so we have moved ahead. We have applied for lookalike status, and we still intend to open up our clinic and serve our area. I wanted to talk kind of about what the unique characteristics of Sweetwater County Community Health Center's new access point application could be. I know that especially in an urban area, perhaps you're just not familiar with the kind of things that we encounter on a daily basis here in Wyoming. Obviously, as you saw the map of our area, we are a large state. We have a huge amount of area to cover, but we have fewer citizens in our state than most urban areas have in a single city. So we don't always meet the mold for what people think as far as numbers and things like that. It's difficult for us. We have, as I have said, a huge lack of providers. Wyoming in general is lacking in providers, but these rural areas, sometimes it's very difficult to recruit physicians to these areas. And sometimes when you can find a physician, their family does not want to follow them. So the physician will come for some time, the dentist will come for some time, but inevitably they leave because their family is unhappy there. It requires somebody who is looking for this type of a living condition, who is interested in probably outdoor activities more so than cultural activities, and that just really enjoys being in this type of an area. We do have a huge amount of collaborative efforts. I am so proud to call these people our partners in what we are trying to do. Our Department of Family Services obviously recognizes that we have a huge need in our area to provide services to those that don't have any options right now. These are people who cannot travel, so going to another area is not possible for them. And we just need to have somebody that is willing to accept that insurance and has the ability to see those patients. The school district has been very, very open to us. We have done a lot of education in the schools themselves, and they are a fantastic partner. They bring an awful lot of information to us, and they know the needs that are out there in the community. I mean, when we communicate with them, we know exactly what they see on a daily basis. Our other physicians in our community are also very, very positive about this. They would like to have some options in order to send their patients to. They know that they cannot see everybody, and they would like to see that our community has good health care that is available to all of the citizens there. The retired and disabled community has also been very, very supportive. We recently have received funding for an ARDC program in Sweetwater County, and that is also a great partnership. We also hope to be able to help them and help to provide them services. We have a fantastic program in Sweetwater County called the Wyoming Health Initiative, or WHI. This is a grassroots program that was developed in Sweetwater County that does a lot of teen pregnancy and parenting. And they have been highly successful, highly acclaimed in what they do. They provide all types of services. They also work very closely with the school district, and they take any girl that is at risk, and they basically take care of her. If she goes to the school and she is concerned about being pregnant, they will provide a pregnancy test for her. From that moment on, she is entered into the program automatically. So she obviously felt that there were some risks that in which she could have been pregnant. So if she's positive, then they take care of all of her prenatal visits. They take care of parenting classes. They provide her some emotional counseling should she need that, and adoption counseling if that's what she chooses. And they hold her hand through the whole program. Once the child is born, we have a program called the Cub House, where the girls can earn points by providing healthy behaviors, and they are provided rewards for that, such as diapers, Tylenol, things like that a young mother might need. So it is a fantastic program, and we're very proud of them also. The YWCA has been a great program for us. They are very supportive. They also have a need in their work with both the young people in their child care programs as well as the women that they see. In Rock Springs, we have a burgeoning Hispanic population. During the last census, we have 18% of our population that is non-English speaking Hispanic. Where our clinic is located is actually in downtown Rock Springs, which is kind of a misnomer because I think you could drive from one end of Rock Springs to the other in probably 10 minutes. But we are in a highly Hispanic area, and we have found that those people, unfortunately, that are among the Hispanic population do have a hard time finding a provider. There are barriers for them, some of them linguistic and some of them cultural. And so we're hoping that we can certainly help them also. One thing that we do have is a lack of supportive funding. Everyone is very supportive of the project, but like most areas, there is not enough money to go around. It is hard to get startup money. It is hard to find somebody who is willing to provide money to an entity that isn't yet seeing patients. So we've had a very, very difficult time in being provided supportive funding. We have went to USDA to get a loan, and that has been a long process, but I do believe it will be successful. And that is one of the few options that is available to a startup entity. Once again, I wanted to talk about our tiny towns. You know, the tiny towns just do not have the infrastructure. None of them have providers of any sort on site, so they rely on some of our larger areas, such as Rock Springs, to help to provide them care. That is not always easy. We're talking about, in some cases, more than 100 miles between the areas. And you kind of have to decide what is better. Do we bring those people to the health care? Do we take the health care to the citizens of those little towns? But I do think that it is the responsibility of us larger areas to help take care of our neighbors that are around us. One of the other things that has recently been brought to our attention with the behavioral studies that were done by the Department of Health is that Sweetwater County has some poor management of risk factors. We rated high on all of the risk factors that were done by the state. This is a very interesting study. I would encourage anybody to take a look at it. It's available online. If you go to the Wyoming Department of Health, and they have a BRFSS tab there, and you can click on that and you can see all of the different counties and their ranking, but it really is quite interesting information. Sweetwater County, unfortunately, rated very high. We have a high obesity rate. We have a high alcohol abuse rate, a high tobacco use rate, a high teen pregnancy rate, and a high rate of lack of health and dental screenings. And quite honestly, I think these all go back to the fact that we don't have enough providers to provide health care for our patients that are seeking health care in our area. We're not providing preventative and educational information, and therefore our risk factors are higher. I think there is a direct correlation between those two things. The other issue that we have is we have a large distance to travel. In order for us to hit any metropolitan area, it is over 200 miles. Salt Lake is right at 200 miles. That is where most of our people go. Denver is probably closer to 250, 300 miles. So we have great distances that we need to travel. The problem with travel is it isn't just travel. First of all, we have patients that are unable to travel. Either they don't have transportation available to them. Wyoming does not have public transportation in most of its areas. So if a patient does not have a reliable vehicle, they cannot travel. Or if they cannot afford gas, they cannot travel. Perhaps they can't afford insurance on their vehicle, so therefore they cannot travel. The other thing that we have is, regardless of your income level, we have problems with our weather. During probably at least 6 months out of the year, there is a high likelihood that the interstate will be closed for part of your travel anywhere in Wyoming. Between the snow, the wind, and the ice that we have, sometimes regardless, you just are unable to get from here to there. That is just something that we live with. We live in an area that is mostly driven by minerals and industry. We have a large mining industry in Sweetwater County. We also have a large oil and gas industry in Sweetwater County. These are great jobs. These are wonderful jobs, and these are huge advantages to our community. The problem is that not everyone works in these entities. So our economy is driven by the higher end jobs. However, not everybody can have one of those. So we have a lot of disparity between our wage earners. We also have some fantastic employers that are able to provide insurance, but we have a lot of little entities, little mom and pop shops, small businesses that unfortunately do not provide insurance to their employees. So that means that they are left on their own for their health care. We have an awful lot of uninsured people in our community. And the last study that was completed by the Wyoming Department of Health Office and the Office of Rural Health, Sweetwater County was named the area of highest need. This designation was made in July of 2009. And at that time, we were short 13 primary care physicians in order to meet the needs of our community. Since that time, we have actually lost 2 more primary care physicians, so that brings our total up to 15. And the result of that is that we have 31,000 patient visits that are not being made. In some cases, those people are going outside of the state, but in a lot of cases, most of those people are just simply not being seen. And so until they have an emergent situation that they need to go to the hospital and they are treated there, they do not have a medical home that they can go to provide care to them. And we are in about the same boat with dental providers also. In fact, with our dental providers, it might even be a little bit worse. Just with the shortage of those primary care physicians, that is a loss of $1.3 million annually to our community. So this is a huge deal, both in supportive jobs that can be provided by having those medical services that are there, as well as recruitment and retention of the people that we want to bring to our community. So we are certainly hoping that we can do something to try and make this easier, and we believe that having a health center is the way to do that. I want to thank you for your time. I want to express my appreciation for you letting me talk about my little area of Rock Springs, Wyoming, and I want to pass the mic back off to Patrick so that he can talk a little bit about Wyoming in general. Thank you for your time.
Thank you, Tina. Some of the issues that are, again, unique to Wyoming, but maybe not to other parts of rural America, are just our overall medical providers. We have a lot of challenge in getting people to come here. Sometimes they come from all over the country. Maybe they've worked in another health center. We have a partnership with Washington State for our medical school, and that's a 5-state partnership between Washington, Idaho, Montana, Alaska, and ourselves. So that actually brings people into the state, but it's a matter of retaining them. And I mentioned one county, Crook County, which is in our northeastern part of the state. They had 3 providers June of last year. One of them unfortunately passed away, and the other 2 were just burned out. And the 2 of them actually left the community, left about 5,000 or 6,000 people without providers. And as Tina had said, well over 100 miles to travel to Rapid City, South Dakota, or 150 to 200 miles to travel to Casper, Wyoming, where we're sitting here today. So I think there's just a challenge. We're asking folks to work in the ER, to work nights, weekends. It's a little different in rural America in terms of our providers when we ask too much of them, and it doesn't matter how much we pay them, but some challenges with just keeping them in any other position, motivated and engaged, especially when they have spouses and young children. Overall, as Tina had said, our state has got some real challenges with Medicare and Medicaid patients in terms of our providers. A lot of them just aren't willing to see the providers for that level of reimbursement. Some of this information is not going to be seen well in grant applications and or possibly in the designation pieces, but we've got a lot of people in here in our state with insurance that do not have access to care. It's a real big issue. And lastly, out-migration. We talked about it earlier. Our state's surrounded by 6 other states, and as I'd said earlier, folks like to leave the state not only for their health care sometimes, but also for cultural pieces. If we had more health centers and people are really starting to understand the benefits of a health center, I think we could retain those dollars both to provide medical care and also to bring some more cultural and other social and economic advantages into our communities. And as I talked about earlier, the economic disparities. When we base some of the models on federal data that's applicable to urban areas, it's really hard to say. You look at per capita income in our state, and it's fairly high. I know it's in the top 10. I'm not sure exactly what it is. In the community I profiled earlier, Jackson, when Melissa and I were up there from the council, one of the folks in the audience said our per capita income in the county is between $70,000 and $80,000. Well, that doesn't take into factor the folks that are making $8, $10, $12 an hour working at the grocery store or working at a T-shirt shop or working for any number of type of entities like that. What it does look at is there's a lot of people that live here that are millionaires, and that's because we have no state income tax. So a lot of those numbers throw our whole demographics completely out of whack. Tina's already talked about our distances between communities and then some of our seasonal challenges, but we've got a lot of issues with weather, but for the summer, which we're just coming out of, that brings a lot of people actually to Wyoming. And that information I can't necessarily put forth on a grant application. We got a lot of people coming here for their national parks and traveling back and forth to, the West Coast, over to South Dakota, those kind of things. That information isn't always reflected well in our grant applications. Some of our challenges. Real briefly, the designations, again, I kind of covered a large part of this, but we have a lot of communities without. We really only have 2 communities, which is our state capital of Cheyenne and then also here in Casper that have possibly even enough providers to meet our medical needs. We have a lot of challenges with people, again, accessing care. That's our biggest issue here in the state. And again, the way the designation requirements are written today, it's a challenge for us to meet those requirements. It took us about 3 years to find a couple of census tracts in Tina's community for us to be able to say, listen, folks, we've got the MUA, MUP, so now we can make that application for the health center. One of the big things that we're looking at here in our state when we go out, and we do a lot of community development, and when I did meet Melissa, it was fresh off of a 6-hour drive from the southeast corner of the state to the northwest corner of the state. But folks say to us, what's an FQHC look like? What does that mean? So we explain to them the difference between what a community health center is and what FQHC look-alike is. And we understand. Tina's working towards that designation. We understand if you get an FQHC look-alike designation, it kind of moves you to the front of the line for at least the community health center funding and potentially other funding, because it tells folks, listen, there's a standard and you know what it is and you've met it and you're compliant with it. But here in our communities, they're telling us, listen, Pat, you know, we have a challenge. We don't have any tort reform here in our state, so that means that our medical providers could be liable with a bad outcome to be responsible for fairly high lawsuits. The other challenge in our state is our reimbursement for Medicaid providers isn't very great. So when we go back to some of our communities and say, if you get an FQHC look-alike designation, you're going to get reimbursed based on your allowable costs for Medicaid and Medicare patients. And that's it. You don't get your federal grant, and you also don't get the malpractice piece. Well, that kind of turns some of our communities off because they come back to us and say, I'm not sure that we really want to give up what we have for that piece here. And that really ties into the last comment. We also understand that for what Tina's trying to do, which is start something from scratch. So she's got a lot, as you've seen, she's got a lot of collaboration, a lot of support in the community. How do we get that actual support on paper? How do we get it as a fully funded functional entity? We can definitely use a satellite clinic approach. But again, when I go back to the communities and I tell them, this is what it looks like if you're a satellite clinic. You would operate under the policies and procedures of an existing health center, and you'd still have your community board, but you'd probably be in an advisory role and or maybe have 1 or 2 slots on the primary board. Folks come back to me and say, Pat, that's not of interest to me. You know why? Because we've got this free clinic that we spent 3 or 4 years operating, putting in place, and then we have 3 or 4 years of successful operation of this clinic, and we don't want to lose our identity. You know, so we've got some challenges, again, that maybe don't exist in other parts of the state. And again, as I say here on the bullet points on the slide, we're putting information and words down onto the paper. When it goes in front of somebody on a national committee to take a look at it, and we've had a couple of new participants to the audience since we started this. For the folks that live in an urban area, they may not understand some of these rural challenges we've talked about here today. So it's really incumbent on Tina and myself to be able to write that picture, to tell our story, so to speak. But if there isn't that familiarity and or maybe experience, it's really hard for a reader who's maybe lived or worked most of their life in an urban area to understand some of the challenges that are in front of us. I always want to kind of follow up the challenges with some opportunities. Again, as I state on the first bullet, when we're taking a look at some of the issues for access, again, it's very hard sometimes for folks to understand. We've got one rural health clinic here in our state that I can think of, and there's more. It's the only provider for several hundred miles around it. There's one provider there. So how many people can that provider really see on any given day of the week or any week of the month? But that is an access issue. So then those folks from that community might drive the 100 miles to Casper, where we're sitting today, for health care. Again, they can shop and those other things, but that's a huge barrier to access. We're a very fiscally and socially conservative state. However, from an opportunity standpoint, our state and local elected officials absolutely love the health center model. So one of the pieces of the legislation that I talked about earlier on requires city council and or county commissioner support of a proposal before an entity could make application to the state for that funding. And when Tina and one of the gals that works at the Primary Care Association got in front of the council, they said, Tina, we're well aware of your challenges. We support you. What do we have to sign? So then Tina and the gal in my office went in the room next door and drafted up the letter, and they signed it. So, you know, our elected officials understand we have issues. You know, my constituents tell me I can't get access to care. And it's access and it's affordability, which of course are two of the big cornerstones of the health center and the health center healthcare for the homeless model. Some of the folks here in our state say that, as we go back to that population map earlier on, that our state could sustain 2 to 3 and maybe as many as 4 health centers. And I'm actually going to take us back to the slide just for a visual one more time as we finish up to show you we've got big areas of our state with population, not the same as upstate New York where I grew up, nor New York City, but if you're looking at numbers in terms of how many people could we see through a new access point application, it's not the same as rural America, but that doesn't mean the impact isn't as strong or powerful. And again, recognized well by our members of our legislature. We hosted a meeting yesterday with, again, some of the folks that sponsored our bill, gave our chairwoman of our health committee an update, and she said, hey, thanks, Pat. Thanks for being out in my community. Thanks for working with my folks. We really hope that someday in the future you could help us get to a health center. Real briefly, some of the topics we covered this morning were just the partnership, and it's been a short-term partnership, but I know it's going to be a long-term partnership moving forward with the National Healthcare for the Homeless Council. Again, we reached out to Jackson Hole, Wyoming, and as Melissa and I were having a conversation with our primary contact in Jackson Hole, this is a woman that's employed by state government who drives over here to Casper, Wyoming, 250 miles one way for her medical care because there's no provider, in her opinion, that is providing a level of care and support that the folks over 250 miles one way. We went over our audience really quick to, just ask you where you were at, and that gave us a flavor for how many folks in the audience were urban and rural, because it would tailor our conversation a little bit. We covered some of our safety net perspectives and some of our maps of the community. And Tina here had the opportunity to share her story, which I think is a great story. It's not unique, but it's a story that's very important to us. And again, we talked about some challenges and some opportunities for us to look at different things here in Wyoming and across the country. And I'm going to take us back one slide. If you look here on this map, and again, you can see the large plots, and it's hard to see here, but one dot equals 20 people. Again, not a whole lot. Our most current census is 563,000 people, not many, again, as Tina had well stated. You know, small cities have 560,000 people. But when we drive on these roads, 2- and 4-lane roads, and we get to these little towns, there's people there. And those people have needs just the same as they do in any other part of the country. We've got a couple of questions that I know Melissa would like us to address, and we're going to kind of turn that back over to her to be able to walk us through some question and answer phase. And I know she wanted to guide us on some things here. So just hold on one second. I'm going to turn the call back to Melissa.
Thank you, Pat. Thank you, Tina. That was a lot of information to digest, and I believe that in archived version, folks will access this information and will probably have some questions about the designation process and why it's problematic. And they'll probably want to know if you've got any kind of statement or comment about the negotiated rulemaking committee. So we don't have any specific questions from participants, but I know that those are two areas that folks viewing this later on will probably want more information. So I'll turn the mic back over to you, Pat. And
Thanks, Melissa. In regards to the negotiated rulemaking committee, we actually had submitted as a state all the way up through the governor's office my name as a potential participant on that committee. And there are some folks on the committee that represent rural America, but we really wanted to be able to say to folks, hey, listen, we have small communities, but as Tina had said, we've got small communities and what does or doesn't happen in those communities is not reflected well in the data. We've got some communities where we've got a high number of folks over 65. The income piece is the one that's really problematic for us, because for us in our state, our biggest employer is state government, and we all know that state government usually provides great benefits, both financially and then health care, retirement, those kind of things. But there's a lot of people working in service industries that are uninsured, low income, managing a couple of jobs, and trying to make a go of it. Also in that industry here in our state, there are very little protections for what we'd call tipped wage earners. So the minimum wage for them is $2.45 an hour. So we know when we go and buy a meal somewhere, somebody's making $2.45 an hour. What about all the folks that aren't very generous in their tipping or don't feel that the service provided them was good? That's not a good wage to raise a couple of kids on. It's very difficult. Some of the other issues with the designation is just we are, there really isn't any tactful way to say this, but we're a population here in our state that's predominantly white. So we are 90% plus white. We've got an Indian reservation, which is Wind River Indian Reservation, has about 12 or 13,000 individuals there. As Tina had said, the state in pockets, both where I live in Cheyenne, over in Rock Springs, definitely up in Jackson Hole, there's a minority population, Hispanic population, but for the most part, we're a state that's predominantly white. So some of the actual disparities that are on the designations are just hard for us to be able to, in terms of just a strict numbers, it's hard for us to meet those requirements. The other question that we had was in terms of what we're hoping for in the future. Again, the current announcements of fundings have come out, and we know that Tina's application, and we've got another one in our state that we think very highly of. It's in Evanston, Wyoming, and it's actually a satellite application for a clinic in Bear Lake, Utah. And the folks from Evanston don't have access to care. They're literally 3 miles from Utah, but they'll drive that 70 miles up to the health center. So the health center approached me because they couldn't get the designation in Evanston. Again, high per capita income, fairly decent health indicators, which is not great to be able to present on our application. And then, the folks of having that opportunity to get out of state. So from what we're looking for in the future out of this is really that opportunity for folks to say, how do we look at the rural versus the urban areas, and how do we adequately reflect need when we know that if we put an application, and let's just even say back in Syracuse, New York, where I'm at, I know there's a health center there. The number of people we can serve in Syracuse, New York is nowhere near the number of people that would be served in Rock Springs. 3 or 4 times the number of people would be served in Syracuse, New York. But the impact of providing that clinic in Rock Springs could be 10 or 20-fold, and that's simply because you take a look at the people that are there and all the issues that Tina had gone through. It's just a difficult between the two. Melissa, we're going to turn it over to you because we do realize that we had a question that popped up.
Thanks, Pat. Vanessa, one of our attendees, asks, do people have to travel over 100 miles for preventive care as well as emergent care? I turn the mic over to Pat.
Yes, Melissa, that's true. And, we're all moving towards the patient-centered medical home concept. And as Tina had said, and as we wrote in her application, there's folks that just can't get in. It doesn't matter, insured, uninsured, and in a lot of our providers just aren't willing, and these are eligible providers that are seeing Medicaid patients. They're just not willing to see the Medicaid patients. Won't openly state it, but they're not willing to do it from a reimbursement standpoint. So yes, we do have a lot of challenges with travel times of 100 miles plus for basic primary and preventative care. We're going to turn the microphone back over to you for any other questions and answers, Melissa.
Thank you, Patrick Monahan of the Wyoming Primary Care Association and Ms. Tina Linkenauger of the Sweetwater County Community Health Center. I so appreciate your time and a lot of information on a segment of community health centers that we could possibly spend more time talking about. So thank you again, presenters. Thank you, participants, for spending an hour with us on the question of rural health centers, Wyoming's story. This presentation is coming to a close, and I guess I just want to direct you to some contact information for both Mr. Patrick Monahan and Ms. Tina Linkenauger, and this will be in the archived webinar as well. There are a variety of resources available to you at the National Healthcare for the Homeless Council's website, www.nhchc.org. I appreciate your time, and I wish you all a good day. This webinar has come to an end.